And without further ado, I would like to introduce our speaker, Dr. Joanna Kee-Sampson. She is an associate professor at Wake Forest Baptist Medical Center in North Carolina, and she was previously the PD for the VIR residency at the University of Florida in Jacksonville. So welcome.
Thank you so much. And my respect to all of you for, especially on the West Coast, for waking up so early to join my talk today. I'm going to go ahead and share my screen here. Hopefully, I'm selecting the right one. Come on. Okay, can you guys see it? It should say, okay,
Perfect. Thank you.
perfect. Okay, so let me just hide this. All right. So, thank you for the introduction. So, I used to be at University of Florida, Jacksonville, until June of this year, where, part of my, I took care of stroke patients. And as a disclaimer, I've kind of moved to Wake Forest now, and I actually don't do stroke anymore. But this is a talk I put together for the IR practicum from last year, and hopefully you'll find some value in this. And this is basically an introduction to taking care of patients with acute ischemic stroke. So in this talk, what I'm going to do is distinguish between the different stroke types, and then just outline the basic evaluation of an acute stroke patient, and talk a little bit about how to select the appropriate patient for endovascular thrombectomy, describe the thrombectomy procedure, and also list potential complications of thrombectomy. So quickly, a few statistics. Stroke, unfortunately, is a leading cause of death in the US and costs the country a lot of money, 56.5 billion between, these are the numbers that we got from 2018, 2019. And strokes, so the risk factors for stroke are a lot of the same risk factors when you look at coronary artery disease and peripheral artery disease. So hypertension, obesity, diabetes, renal failure, smoking, for example, all of these risk factors that causes coronary artery disease are the same risk factors that causes stroke. So the rate of death from stroke is not distributed evenly across the country, as you can see. The areas with the really dark purple are the areas of the country with the highest rate of mortality from stroke. We call this area the stroke belt. So down here in the southeast is where we have the most concentrated, highest mortality from stroke. And then the stroke buckle are the states of North Carolina, South Carolina, and Georgia. So why the higher stroke mortality in these areas of the country is primarily driven by the higher stroke incidence because of the higher prevalence of the risk factors. So higher degrees of high cholesterol, heart disease, hypertension, diabetes, and smoking, etc. So historically, the overall average stroke mortality has been 30% higher in the stroke belt and 40% higher in the stroke buckle compared to the rest of the country. So overall, there are two general types of categories of stroke. We have hemorrhagic stroke and ischemic stroke. Hemorrhagic stroke is the smaller percentage or the minority of strokes. 10% of them are, present as intracranial hemorrhages. 3% of them present as subarachnoid hemorrhage. And generally, these are managed by medical management or surgical management. But by far, the most common type of stroke is ischemic stroke. And this is by far the most common type, not just in the US, but also globally. and they can be from an embolic source or thrombotic source. And the treatment for that, prior to, the stroke trials in 1995, where they looked at the benefits of intravascular TPA to treat strokes. Prior to that, there was really not a lot of treatment options for acute ischemic strokes. But after that trial, obviously we have, in addition to intravenous thrombolytics, we now have, endovascular therapy as an excellent option for patients presenting with acute ischemic strokes. So like I said, ischemic strokes can be from embolic or thrombotic source. Embolic, the most common place for clot to come from is the heart. And this can be from the valve or from the chamber. So for example, in patients with atrial fibrillation, that is one of the most common source of embolic source for ischemic strokes. Vessels can also be an embolic source. Now you can have atherosclerosis as a source, but also can occur in patients without atherosclerosis. So think of the younger patient with vessel dissection, for example, as a source for clot to lodge in the brain. Thrombotic causes of ischemic strokes, now that could affect small vessels or large vessels. When it affects small vessels, we call those lacunar strokes. When it affects larger vessels, those are, what we call large vessels are basically anything involving the ICA, MCA, for example, or the proximal ACAs. So some basic anatomical review. So we have the anterior circulation, posterior circulation, and the ACA, the MCA, the distal ICA compromises it makes up the anterior circulation. And the posterior circulation is made up of the vertebral arteries joining to make the basilar artery, and then divides into the posterior cerebral arteries. And of course, this circulation is a circle, right? So we call this circle of Willis, because if it's a circle, so that when you have a vessel that's occluded, you have the anterior circulation can compensate for the posterior circulation to a degree, right? And the posterior circulation can compensate for the anterior circulation to a certain degree. So here are two cerebral angiograms. On the left is an AP view looking at the patient from an AP direction. And this is lateral view looking at the brain from a lateral, from the side. So we have the ICA, the terminal ICA divides into the MCA and the ACA. So the first, or the horizontal portion of the MCA, is called the M1. And as it divides, it becomes the M2. And then the M3 are kind of like the opercular branches, and the M4, the distal cortical branches, supplies the distal cortex of the MCA territory. The ACA, before it communicates with the other side, it's the A1. And then after the anterior communicating section, it becomes the A2. And on a lateral view, the ICA, the petrous ICA, has two portions. It has a horizontal portion and the vertical portion. And it becomes a cavernous ICA. So the petrous portion of the ICA and cavernous ICA are actually outside of the dura. So these are the extradural portions of the ICA. And then after the origin of the ophthalmic artery, it becomes the intradural portions of the ICA. And here is the posterior circulation. So the posterior circulation comes up to vertebral arteries, right and left, joins together from the basilar artery. Off the two vertebral arteries, you have the posterior inferior cerebellar arteries. And then after it joins to become the basilar artery, then you have the anterior inferior cerebellar arteries. And then as the last divisions off of the basilar arteries are the two posterior cerebral arteries, which are these two arteries you see above the tentorium. So, in the literature, the literature kind of divides vessels into large vessels and medium vessels, and then small vessels or distal vessels. Very commonly, it can be kind of confusing because the definition of what's large and medium vessel varies depending on which paper you read. But in general, the large vessel, when we talk about large vessel, we're talking about the A1, the M1, the terminal ICA, P1 and basilar artery. And then the divisions off of that, we consider the medium vessels. And then the further smaller vessels off of those are considered the distal vessels. So in terms of endovascular therapy or thrombectomy for acute ischemic stroke, 2015 and 2016 were really the seminal years because of a large number of of randomized controlled trials that came up that showed the benefit of endovascular therapies for acute ischemic stroke. And the Hermes collaboration is basically it's a meta-analysis that was published in 2016, looking at these 5 seminal stroke trials, Mr. Clean, Escape, Revascat, Swift Prime, and Extend IA, which combined all of these, the data from these 5 seminal stroke trials, which showed a benefit of endovascular thrombectomy over just medical management alone in anterior circulation, large vessel occlusion strokes within 6 hours of onset of stroke symptoms. So not only is endovascular thrombectomy superior to medical management alone in acute ischemic strokes, but the impact of this procedure was also known to be extremely significant. So there is a concept in the scientific literature and medical literature of number needed to treat. So this number needed to treat is how many patients you need to treat in order to see significant benefit in improvement of the clinical symptoms that you're trying to treat. So in stroke, in endovascular thrombectomy and large vessel occlusion, the number needed to treat to prevent patient from having or to have a patient have less disability at 90 days is 2.6, meaning that you only have to treat about 3 patients to help 1 patient have less disability from their acute ischemic stroke in 90 days. And the number needed to treat to prevent a patient or to have a patient be functionally independent in 90 days is 5, meaning that you only need to treat 5 patients to help 1 patient have less disability in 90 days. So this is very significant. These are really extremely significant numbers. When you look at the number that needed to treat to do a percutaneous coronary intervention for STEMI. So comparing this to PCI, primary PCI for STEMI, right? So primary PCI is the gold standard procedure when someone's having a STEMI. So there are a number needed to treat to prevent 1 patient from having a death at a short term. In the short term is 45, and to prevent a death in the long term is 29. So looking at the numbers needed to treat for acute ischemic strokes, this is significantly more impactful than even a gold standard treatment algorithm, which is PCI for STEMI. And then, your question may be, well, those early trials kind of only looked at early ischemic stroke patients, right? Patients presenting within 6 hours of last known normal. What about, patients presenting beyond 6 hours? So Diffuse 3 and Dawn were 2 trials that were published in 2018 that actually saw a benefit for endovascular thrombectomy for this group of patients compared with just medical management alone. And so this actually extended the time window for endovascular treatment for acute ischemic strokes to patients presenting with symptoms beyond the 6 hours, up to 24 hours. So the important thing to know about treating stroke is that it's a team sport. Time equals brain, and because the end goal is to get the patient's cerebral perfusion going as soon as possible. It is really a collaborative effort to, treat stroke. So if you look at any high level or level one treatment, level one stroke centers, or comprehensive stroke centers, you're talking about working with EMTs, rad techs, nurses in the ED physicians, the stroke neurologist, and endovascular physician, be that, neurosurgeons or IRs or interventional neurologists. All of these people have to work together well as a team in order to reperfuse the stroke patient, as the patient presenting with an acute ischemic stroke, as soon as possible. So that's something to remember if you are going to eventually end up in a position to offer endovascular therapy for these patients, is that the system has to work well together in order to help the patient. So moving on to evaluation of the acute stroke patient, right? I'm going to talk a little bit about clinical evaluation and then imaging evaluation. So the clinical evaluation of the stroke patient, there is the basic way of categorizing how severe a patient is presenting or how severe their symptoms they have is an NIH stroke scale score. So it goes from 0 to 42. The higher the number, the higher the stroke scale score, the worse their symptoms are, or the more severe the symptoms they have. Last known well is a concept to describe the time at which the patient was last seen to be at baseline neurologic function. So that is a very important concept to keep in mind when you're considering or trying to select patients for endovascular thrombectomies, or if considering giving them intravenous thrombolytic drugs. The next concept is the baseline functional status, or a modified Rankin scale. So this kind of, it's a description of how well patient's baseline neurologic function was. If they were completely normal before, their MRS, or modified Rankin scale score, is 0 and ranges from 0 to 6. Obviously, hopefully they're not a 6 when they're coming to you and you're considering to do endovascular thrombectomy. But this is important, right? Because we want to eventually help patients have less disability, right? That's the whole goal of endovascular thrombectomy for these patients. So we typically will select patients that do not already have an MRS, or a modified Rankin scale score of 4, if they're already, or 4 or 5, right? If they're already severely disabled, you can't really help them get to a score of 0 to 3, right? And then moving on to imaging evaluation. So the first imaging evaluation that all stroke patients or patients presented with stroke symptoms will get is a non-contrast CT head. The purpose of this is to exclude any hemorrhagic stroke as the cause of the patient's neurologic symptoms, because if they have a hemorrhagic stroke, you don't even want to consider giving them intravenous thrombolytics, right? That's a contraindication. And then the non-contrast CT head is also done to exclude other causes of neurologic symptoms. For example, on the CT, this patient actually had this hyperdense mass in the head, in the brain, and that was the underlying cause of their stroke symptoms. And then, the third purpose of this non-contrast CT head is to, determine whether they can receive the thrombolytics, right? If they are presenting from their last known well of within 4.5 hours and they have no other contraindications, and it's a negative CT head for any intracranial bleed, then they could potentially be given the intravenous thrombolytic drug. Another thing that a scoring system that we use a non-contrast CT head for is called aspect score. And this is short for the Alberta, this Alberta stroke program early CT score. So basically, it's a 10-point system, and you subtract 1 point for any areas of loss of gray white junction or hypodensity. So these are surrogates to determine basically areas of completed stroke, and it's a selection criteria for endovascular thrombectomy and also for selecting patients to give thrombolytics to. So the higher number of points, the better. So the lower aspect score means the more areas of the brain are involved in the stroke. So that's why a 10 is good and like a 5 is bad. Other things that you may see on non-contrast CT scan is something called hyperdense vessel sign. A lot of times acute clot, because of the density of the clot, it actually shows up more dense than the other vessels. And that can be a clue to where the occlusion is. So in this case, this is a non-contrast CT head. These are the MCA vessels. You'll see that there is actually a density in the right M1 compared with the left side. And this is actually the site of the occlusion or the site of the clots. So this is called a hyperdense vessel sign. And then moving on from the non-contrast CT, we typically then do the CTA or CT angiogram of the head, including the neck. And the reason to do the neck is to ensure that there is adequate information about the top of the arch and anatomical evaluation from the origin of the great vessel, so that this is for procedural planning, and also to see if there is any issues arising from the vessels that are more proximally that could be a cause of the stroke. So this is a prime example. If you look at this patient's CTA, this is a 3D reconstructed view of this patient's top of the aortic arch and proximal vessels. This is a prime example where like the CTA, including the neck, would be very helpful for procedural planning. You see those in the ICAs, right, coming off really like very circuitous, very almost like a 360-degree turn. So when we see a patient like this, and we have to plan the best and fastest way to get up into the intracerebral vasculature, sometimes we may decide to not access via the femoral arteries. Maybe decide to go through the radial arteries to do their thrombectomies. And then, perfusion scans. So basically, perfusion scans are scans that measure blood flow to a given volume of brain. And it could be done with CT or MRI. And why it can help is it can help assess the volume of brain that could be saved, or what we call the penumbra, versus brain that's already dead from the infarct. And it can help with selecting for patients for thrombectomy, especially for those patients presenting with symptoms beyond the 6 hours from last known well. So up to 24 hours, but beyond the 6 hours. So there's a lot of concepts to kind of really understand in a CT perfusion or any perfusional scans, but the four main parameters to understand are time to peak, or otherwise called as Tmax, mean transit time, cerebral blood flow, and cerebral blood volume. Now, I think the best way to really understand this is to kind of use plumbing as an analogy to kind of understand some of these concepts. So time to peak, right? So time to peak is how long it takes blood flow to reach its highest point after you inject the IV dye or IV contrast. So if you think of plumbing, it's like how long it takes for water pressure when you turn on the faucet, how long it takes water pressure to reach its maximum after you turn on that faucet. So that's time to peak. The mean transit time, this is the average time it takes for blood to pass through a specific area of the brain. So going back to the plumbing analogy, this is how long it takes from water to travel from one end of the pipe to the other end of the pipe. That's the mean transit time. Cerebral blood flow is measuring how or the amount of brain passing through a specific part of the brain each minute. So it's looking at the pipe when you turn on the faucet, it's looking at the volume of water that flows through a pipe per minute. And then finally, cerebral blood volume. This is the total volume of blood in a given volume of brain. So in a given volume of brain is a total volume of flowing blood. So going back to the plumbing analogy again, this is looking at the amount of water in the water tank. So here's a patient's CT perfusion scan. This is a case of a right IC occlusion. So tissue at risk, or what we call penumbra, are tissue or brain tissue that's not dead yet, but it's at risk of being infarcted because of the decreased blood flow to it from the clot. Infarcted tissue is already, brain tissue that's already died because of lack of blood flow. So looking at those parameters, the tissue at risk will always have, and both tissue at risk and infarcted tissue will have increased mean transit time and time to peak because it takes the blood longer to get there because of the clot. However, if you look at cerebral blood volume, in tissue at risk, the cerebral blood volume will actually be normal or actually slightly elevated. And that's because this is from autoregulation. This is from autoregulation of the brain where you have these arterioles dilate temporarily to try to increase blood flow to the brain tissue. And that's why tissue at risk will have normal or elevated cerebral blood volume. But in infarcted tissue, so infarct tissue is not able to have that autoregulation, right? Infarcted neurons are not going to have that ability for autoregulation. Therefore, their cerebral blood volume and cerebral blood flow would be severely decreased because there's no blood getting to it. So CT perfusion is not a perfect scan. There are limitations. When you do a perfusion scan in somebody that's presenting within 90 minutes of symptom onset, it can overestimate the amount of core, the amount of infarcted tissue. And also anything, because because a perfusion scan, again, is estimating how much blood flow is going to the brain tissue. Anything that can decrease blood flowing from the heart to the brain. So imagine that could be anything related to the heart, like arrhythmias, any vessel stenosis along the way, can all result in very unhelpful perfusion maps. And finally, the perfusion protocols that are designed are mainly designed to look at the anterior circulation. So it's really not validated to look at the posterior circulation. So that's just caveats to keep in mind when you read a CT or MRI perfusion scan. And of course, like AI is very much entrenched in our lives nowadays, and in medicine especially, right? And AI actually helps a lot in stroke imaging by helping get patients from when the onset of their stroke symptoms to the endovascular table, from the angio table to get their endovascular thrombectomy. So AI, actually, there are different softwares out there. There's Rapid, Viz AI softwares out there that automatically calculates. This is the aspect score off the non-contrast CT head. Automatically calculates the perfusion maps to tell you what's infarcted and what's penumbra, and the mismatch in what's infarcted tissue versus what's salvageable tissues, and also automatically picks up occlusions on the CT angiogram. So these are all very helpful tools to kind of help select patients for endovascular thrombectomy. And this is also a communication system. A lot of times all of these programs have apps that you download onto your phone, and you can easily look at all those selection criteria on your phone, on the perfusion maps. You can look at the angiograms. You can look at the non-contrast CT scans, and then you can actually send out a mass page onto your stroke team and kind of call them in all at once when you decide a patient is a good candidate for thrombectomy. So looking at patient selection for endovascular thrombectomy, and these are from this 2019 stroke guidelines, and they haven't been updated yet, although I do anticipate that they probably will be updated soon because of some new data that have come out since then. But these here are strictly, from the 2019 stroke guidelines. So basically, how do you select a patient for endovascular thrombectomy? So generally, the patient should have an NIH stroke scale score of 6 or greater, meaning that they have, symptoms, not just mild symptoms, but symptoms that are severe enough, to take them for an endovascular procedure. Their baseline functional status should be 0 to 1, so fairly normal functional baseline. Aspect score, again, this is the CT, aspect score should be greater or equal to 6, meaning that they do not have extremely large areas of completed infarct, and there are potentially areas of salvageable tissues that are worth taking them for a thrombectomy for. And they have occlusions of, ICA or large vessels or medium-sized vessel. And that treatment can be initiated within 6 hours of symptom onset. And of course, as I said, the Diffuse 3 trials, that have extended the time frame of eligibility for endovascular thrombectomy of patients presenting with a large vessel occlusion. So that's also, those patients up to 24 hours can also be selected for endovascular thrombectomy. Now, this kind of throws a little wrench in the 2019 AHA stroke guidelines. In the last couple of years, there have been several prospective trials that show the benefit of endovascular thrombectomy in these acute stroke patients, even with very large, what appears to be large ischemic cores. Now, these are the patients with infarcts that are aspect scores now between 3 to 5, right? In the original guidelines, it was aspect score of 6 or better. So now we're looking at potentially performing endovascular thrombectomy in patients with even larger cores, with core volumes of potentially of 70 milliliters or larger, and even getting a benefit in this group of patients. So, stroke guidelines or how to select patients for thrombectomy for acute ischemic stroke, these are moving targets all the time. And so as a result of these large core stroke trials, there actually has been guidelines from SNIS in selecting patients in recommending endovascular therapy for these patients presenting with large ischemic cores. So my guess is the AHA stroke guidelines will be updated soon. And so, when that happens, obviously, a lot of practice will change, and I think more patients will qualify for endovascular thrombectomy. So shifting away from how to select patients to kind of how to do this. First of all, endovascular thrombectomy basics, general anesthesia versus sedation. Like, do you put the patient out completely, or do you just sedate them lightly for the procedure? It really depends, and some of that, it depends on the institution. And where I did, the stroke thrombectomies, we very often just did all of the patients under general anesthesia. The benefits of that is that, you have a patient who's not moving on the table, and your imaging is better. So therefore, it allows you to do the procedure a little faster. I have also done it with sedation where I trained. We did some patients under sedation and some under general anesthesia. It can be done both ways. So it just really depends on the hospital resources and kind of what is common practice at the institution that is doing the strokes. So vascular access. So you got to have a way to get to the brain somehow, right? So most common access route is still femoral, is through the common femoral artery. But depending on the patient's anatomy, their arch, tortuosity, radial is a very viable method of doing stroke thrombectomies, especially for posterior circulation. And now there are more and more devices being made, especially for radial access stroke thrombectomy. So that makes it a little bit easier to do radial access for thrombectomy. And then carotid. This is not a very common route of access, but definitely, a one of the routes that the kind of routes of last resort is stick the common carotid artery directly and go up into the brain for thrombectomy. And I have done that about 3 times in my life. Not a first choice for access, but kind of an access of last resort. Selective catheters. So all of the catheters that we use for stroke thrombectomy has to be fairly long, at least 100 centimeters. And you notice that a lot of these are reverse curve catheters, meaning that they have 2 curves on the catheter tip, where there's a primary and secondary curve on the catheter tips, and the 2 curves curve in different directions. So those are very helpful. These catheter shapes are all very helpful in selecting, the great vessels off the aortic arch. And then the next thing is a support sheath. You have to have a stiff enough support sheath to maintain access into the carotid artery. And then intracranial aspiration catheters or intermediate catheters is kind of the next step. And these catheters can be both for support and for aspiration. And then microcatheters are used if stent retrievers are used for the mechanical thrombectomy. So we'll go through a couple of cases and we'll go through some of these equipment as part of the discussion. So there's a myriad of different, manufacturers of stroke thrombectomy devices out there. I don't think that I've used different ones. I've used Zoom, Penumbra, different companies' devices. I really think that you just have to get really good at using a narrow set of devices. I think they all function very well. I think you just have to use a lot of a specific kind of device to get really good at it, rather than, not being familiar with, one particular device because you're just using too many of them, if that makes sense. So I don't think any one of them is like the best, for example. All right, so case 1. All right, so let's go through some cases and we can talk a little bit more about devices and different techniques for thrombectomy. So this first case is an 80-year-old man who was brought to the ED as a stroke alert. He had rear-ended another vehicle, got out of the car, and then just collapsed to the ground. So he arrived in the ED fairly early, within half an hour of his symptom onset. He had a right hemiplegia, right facial droop, global aphasia, left gaze deviation. So his stroke symptoms are very severe, right? So 26 is a very high NIH stroke scale score. He was given TPA in the ED because he fit criteria. And then this was an initial CT, non-contrast CT head. So aspect score, I would say that this is a very high aspect score because I don't see a lot of areas of loss of great wide junction or hypodensity. So I gave him an aspect score of 10. I would give it 10. So this is a 3D kind of reconstructed view of the CTA of his head, which shows a left M1 occlusion. And this was a CT perfusion scan that was done right after. The mismatch volume is very high. I think that based on the CT perfusion scan, there was a lot of areas of penumbra, a lot of areas of tissue at risk that's worth saving. And so we brought him for thrombectomy. So here's the initial left ICA angiogram, which showed a severe stenosis at the ICA bifurcation here. And in order to get our devices beyond this stenosis, we had to angioplasty it when we did it with a 5 mm balloon just to enable our devices to kind of pass beyond the stenosis and be parked in the ICA. This is the initial angiogram, ICA angiogram through our intermediate catheter. Here you see the cutoff here, the MCA occlusion there. So there is ACA here, ICA terminus, and an M1 occlusion right there. And this is an angiogram through, so once we pass the occlusion, so you see the A68 intermediate catheter here. Here is the microcatheter. This is the area where the occlusion would be. The occlusion was crossed with a microcatheter, and this was an angiogram done beyond the occlusion. And this was, we utilized the captive technique to do the thrombectomy in this case. And what that is using a combination of a stent retriever, which you see this here, and an aspiration catheter to pull the clot out. So how we did this was we deployed the stent retriever across the clot, advanced the aspiration catheter right up to the face of the clot. We let it dwell for a few minutes and then pulled both out as a unit. And this was our post thrombectomy angiogram, which showed complete reperfusion of all the MCA territory. So the modified Tiki score is a grading system we use to assess how much reperfusion we have restored after the thrombectomy procedure. So in order, the reperfusion score that we're aiming for when we do thrombectomy is at least a 2B. So at least reperfusion, which is substantial reperfusion to the distal branch, filling at least half of the territory that's visualized. A modified Tiki 3, which was what we got in the previous patient, would mean that we have complete reperfusion and with normal filling of all the distal branches. So here's a follow-up non-contrast CT after the thrombectomy. We did not see any areas of loss of gray white junction or hypodensities to indicate that he had any completed infarcts. And actually, clinically, he did very well at 24 hours. His NIH stroke scale score dropped from 26 to 1. He had some minimal residual right upper extremity weakness, but clinically, but that was it, right? Like from 26 to 1. So, these are just some specific technical notes about what we used. Again, we use usually a sheath to park our cells in the cervical ICA. And then we use microcatheters. In this case, we use microcatheters to get beyond the thrombus. And then we use an intermediate or aspiration catheter to help us remove the clot. And case 2 is an 83-year-old woman with atrial fibrillation who presented to the ED an hour after the onset of stroke symptoms. She had decreased, she had left upper extremity weakness, but also decreased consciousness. Her stroke scale score was fairly high at 16. She was on warfarin and therefore was not given thrombolytics. So here is a non-contrast CT scan. Now, remember how we talked about one of the things that we look for on non-contrast CT scan is the hyperdense vessel sign. So in this case, we see this hyperdense vessel here, and this is the basilar, the tip of the basilar artery. So this is the CTA. You could see that this is the opacified basilar artery and then the thrombus in the distal basilar artery. So this is a posterior circulation stroke. So we proceeded to access her right vertebral artery to get up to the basilar artery here. And here's a right vertebral artery angiogram through our sheath. Okay, so you see that very slow flow through the right vertebral artery because of that distal basilar artery occlusion. And this is the angiogram through our microcatheter after we got through the occlusion. And this is actually the thrombus here sitting in the distal basilar artery. Here's our angiogram through the microcatheter after we got through the occlusion. And this is post-thrombectomy. AP and lateral view. So now we no longer have the thrombus in the distal basilar artery. We have complete reperfusion of the posterior circulation here, both on AP, you see the cerebellum, see the posterior cerebral artery distribution here. And this is a different patient also with a basilar, distal basilar artery occlusion. And this is just to show you a different way of getting to the vertebral artery. This is through a radial access. So there's a sheath there with a reverse curve catheter that we nudged up into the vertebral artery and did thrombectomy through that radial access. So obviously a different patient. So this patient had some residual, post-thrombectomy MRI was done, and there were some areas of completed infarct in the pons and in the left cerebellum. But her NIH stroke scale score at 24 hours was much improved compared with, presentation. At presentation, she was 16 and she had some residual left upper extremity and left leg weakness, some mild dysarthria, but improved. And these are just some of the devices that we used. I don't want to get into too much of that, but okay, this is the next case. This is a different patient presenting with acute stroke after cocaine use. She had presented much later, than the previous two patients, to the ED 330 minutes after onset of symptoms, fairly high stroke scale score of 15. She was unable to really fully follow commands. And because she was outside of the window, the 4.5-hour window, TPA was not given. Stroke scale or aspect score, not terrible, 8 to 9. And on the CTA, she actually had a tandem occlusion. So this is tandem occlusion was where you have more than one occlusion in the same kind of inline vessel. So she had an ICA and an M1 occlusion. So she had adequate volume or mismatch volume for us to pursue endovascular thrombectomy, and that's kind of what we did. So she had an ICA occlusion, which we cleared out first. And then we went out for the distal occlusion in an M2. And our final reperfusion was TK2B. It wasn't a TK2C because we reperfused at least 50% of her MCA territory, but not completely. There were some persistent kind of very distal branch occlusions that were too distal to individually pursue. And this was her MRI after thrombectomy with some areas of completed infarct. So she unfortunately did have a large area of completed infarct with some hemorrhagic conversion. She did, like, her presentation was like 330 minutes from her last known will. And she did end up with, unfortunately, did end up with some dense right hemiplegia, was very, some severe speech issues, and she was discharged to rehab. So the next section is just to review some challenges and complications that happen with endovascular thrombectomy. First is reocclusion. A lot of times, when we're dealing with a population that has, um, risk factors, right? Like we discussed, risk factors for very bad vessels, right? Cholesterol, high cholesterol, diabetics, etc., patients with renal disease. So a lot of times we have what's called ICAD, patients with ICAD, intracranial atherosclerotic disease. And so this was a case of a patient with pretty severe intracranial atherosclerotic disease who presented with a right M1 occlusion. After the thrombectomy was performed, they immediately reoccluded because of the severe underlying intracranial atherosclerotic disease, and that necessitated putting a stent to keep that M1 open. So it's a little tough to see it here, but there's a stent here. Vessel perforation. So sometimes, patients may have very bad underlying atherosclerotic disease, but also you're going out to the very distal vessels. So have to be extremely careful, when you are out with the microcatheter, microwire. We are always very careful with that, but this is a case of a vessel perforation in a distal branch here during thrombectomy. And then embolization to a new territory. This is something that definitely can happen when you're doing thrombectomy of more proximal thrombus. So here's the case of somebody with an IC thrombus, did the thrombectomy, but there was showering of smaller clots to the distal M1 branches that weren't there before. So in this case, then you have to, if they're proximal enough, you have to go out to get some of the more proximal branch emboli. If they're distal, then sometimes you may not be able to get the more distal emboli. Dissection, here's a case of a ICA dissection during thrombectomy attempt. And then this was, this is something, unfortunately, that doesn't happen very often. This is kind of a fluke. It was one of my partner's cases. He was using a thrombectomy device that has now been pulled off the market, actually. And it was, let me see if I have more pictures there. So, yeah, so the device actually ended up with a hole in it, and kind of the tip of it broke off completely. And as part of the procedure, caused a carotid cavernous fistula, and the catheter tip actually broke off completely, and my partner actually had to go fish it out of the patient's head, and had to then also embolize the carotid cavernous fistula. And this was the piece of the catheter that had broken off and embolized. Fortunately, something that rarely happens, but something to kind of, when things like this happen, you gotta have to have a backup plan and think how you're going to manage some of those complications. So I know, in the audience, like most of you are probably students and residents at the moment, but let's say, you are interested in doing stroke eventually. One of the questions is, if you don't follow a neurointerventional pathway, like how do you get more training to do stroke. I would say that there are plenty of IRs doing stroke thrombectomies out there, especially in like private practices. Your partners, your future work partners would be a great resource for training. And so I trained to do stroke in fellowships. And when I joined University of Florida, Jacksonville, we had new partners come in without any previous stroke thrombectomy experience, and I helped train them up to do stroke. So I would say partners are a great resource. Observership at a high volume stroke practice is also something feasible. And finally, SR does put out a stroke course every year. That's excellent. And that's also a good resource to learn how to do stroke if you, do not intend to follow the neurointerventional route. And here are my references.
Wow, that was amazing. Thank you so much for giving us those clinical pearls and sharing those cases.
I hope that wasn't too much because I wasn't sure, if it's mostly medical students or residents that are part of the audience, but yeah.
Yeah, I'm going to open the floor up to questions. And I'll start us off. I was wondering if you'd discuss one of the cases that you had to use carotid access to do the thrombectomy. Like, what were some of those cases, one of those three cases?
Yeah, so you saw one of the CTAs, that patient with the really like 360 kind of roller coaster carotid. So that was one of the patients that we did direct carotid access on because a lot of times when you have anatomy like that, your devices will not go up, into the distal cervical carotid. So in that case, we just ultrasound, we found the common carotid artery and directly accessed it. And so, with a sheath directly in the neck, and then did our thrombectomy that way. And then we closed the access site with angioseal in that particular case. And actually, in all three cases, I closed them with angioseal.
I have another question. You had
Sure.
mentioned stent retrievers and aspiration thrombectomy and all the different tools that we use. And I was kind of wondering if you are always using in your practice, if you're always using this combination of stent retrievers and aspiration thrombectomy, or if you're just solely using mechanical thrombectomy sometimes, and how that decision making goes for you.
So I have found that, like there I kind of evolved. So in training, right, I used a lot of combined stent retriever and aspiration catheter, like using the slumbra or captive technique. And that was because, that was kind of what my attendings did. And, that was primarily kind of the way I did my thrombectomy. So I took that to my practice. So my early years practice, that was primarily the way that I did my stroke thrombectomies. And then, as over the years, they developed better and better kind of larger bore thrombectomy devices. Um, that tracked better. And I started doing more just aspiration first, meaning that I just, without the stent retriever, just did the aspiration first to clear it. And so then I kind of evolved to do kind of a combination of like just aspiration first, and then some patients I would still do the captive technique with a stent retriever. So that kind of evolved over time. And then as the devices evolved to be more effective in more small vessels distally. In those vessels, and I use primarily aspiration first, because when you have to go out to the more distal vessels, you don't want to drag like the stent retriever in a smaller vessel. So those primarily is just aspiration only. Yeah, so I would say like it's evolution, like, and I think that's what most people do in practice is as as different devices come out and maybe the data on certain techniques come out, this works better for this place, this works better for that place, that they may kind of change their practice to suit that.
That's really helpful. Thank you.
Yeah,
And I just had one other question, if you don't have
sure.
any other ones. So you had mentioned kind of this utility of CT perfusion in
Mhm.
evaluating the penumbra, looking at the mismatch score, and we were talking about intracranial athro. And my understanding is that for people with intracranial athro, if they do have symptomatic athro, you can try DAPT a little bit first before deciding to whether or not you can stent. Because I know
Mhm.
like stenting doesn't really have great data around it. But I was kind of wondering if you ever use CT perfusion to evaluate the need for a stent when you do place a stent and how that decision making goes as well.
I think that this decision for a stent really happens during the case. Um, and generally, if I'm doing a thrombectomy and it reoccludes right away, so one of the things, I would do as part of thrombectomy is you wait a while and you re-inject, especially in somebody with really bad intracranial athero. You re-inject, and if it looks like it's not going to stay open, just going to reocclude, you want to stent. And that decision is made at that time to stent. Because otherwise, like everything that you've done would have, you know, been for naught, right? So, yeah.
Thank you.
I had a quick question if you have time. I was
Sure.
just wondering if you could speak to like, I guess medical management or like your post-operative follow-up after the intervention, if you follow them or if you just kind of like leave it up to the stroke neurologist, and then at those visits, like what kinds of questions you're asking or like what you're looking for.
Yeah, generally the practice at at UF was, we would follow them after they go to the neuro ICU, for a few days and just to kind of follow their recovery kind of recovery or, because just kind of so that we know. But then on discharge, they generally just follow up with the stroke neurologist at discharge. Yeah.
Got it. Thanks.
Yep.
And I had one more question if you have the time
Sure.
for it. I was wondering when you were speaking to the embolic showers, it sounds like a lot of these techniques do put patients at risk for, additional emboli breaking off and going off into distal vessels. Is that just a part of the risk, or what techniques do you utilize to mitigate that complication?
Yeah. So, there was a while where a lot of people were using balloon occlusion catheters as a way to mitigate the embolic risk. So, the balloon occlusion catheter has a balloon at the tip, which you inflate. And, theoretically, you inflate it, you do your thrombectomy, you've arrested forward blood flow, and you're so theoretically reduces that embolic risk. Um, but, I think that, some of the data that came out showed really no difference, right, between using a balloon occlusion catheter versus not. So I think people have moved away from using a balloon occlusion catheter. Now there are like bigger aspiration devices that that people have started using that I guess mitigates the embolic risk by, just more efficiently sucking out the primary clot and instead of kind of like coring through it and allowing for little small pieces to break off. So, there are kind of like device mitigated or device usage strategies to mitigate the embolic risk, but I think that you still have to we when we talk to patients' family, we still tell them about the embolic risk. It's still there, it doesn't mitigate it. Like the technique doesn't mitigate it 100%, depending on where the clot is and depending how like soft it is.
All right, well, this was a wonderful discussion. Thank you so much for your time. I want to be respectful of your time, so I'm going to wrap up here, but please feel free to leave contact information for everyone else to reach out for additional questions.